Good evening, everybody. Welcome back to part two. Just give us a couple minutes while we wait for other people to join. Before we get started with part two of Bra Day, I'm going to bring on a special guest as a surprise visit, as we have chosen the winner for our giveaway today. And we always talk about family members, support, caregivers, and connecting with somebody who I have spoken to for many years. And she happened to just comment that her mom needed prosthesis. Hey, how are you?
Hi, you look cute. I'm good. How are you?
Thank you. Well, you have a 3-week-old baby. Let's be honest, right? Like, mom life changes how we like get together in the beginning, but after a while, it comes together. How are you?
I'm good.
Oh,
I didn't think I'd be saying that at 3 weeks, but I'm good. So
great. Well, first and foremost, I really want to take the time and thank you for always following Brecker Strong, always commenting, always sharing what we do. And, today's giveaway was a little different than our other giveaways from earlier in the week or this week. Today was very personal. Today was if you were affected or somebody who was affected, that's how the winner was chosen. And, throughout the day, I kept watching. And then all of a sudden I saw you post and, about your mom. We would love to be honored to gift her, obviously, two prosthesis for her to wear as a breast forms. And what I will need from you is just to find out her size, and we will go ahead and get them ordered and shipped. It'll probably take about 7 to 10 business days by the time we order them when we get them shipped. But I just wanted to come on, announce that your mom was the winner. I know she's not on Instagram, but I know as a daughter, BRCA positive, the life that we live, I think it's important. And I really appreciate you coming on and following us and doing all the stuff that you do in our
yeah, I love
community.
you. I mean, I think you guys are amazing. And it's just, even if your insurance covers this stuff, I was just telling my husband, I was like, you gotta watch the baby. I gotta hop on. I gotta hop on this live because insurance with the forms, they'll only cover the really basic one. Like if you want to use one of the ones like this one that's more fancy, they're like, no, no, we're gonna cap you, and then you have like the remaining $200 to pay on it. Or they'll do something stupid and be like, oh, you're missing both your breasts. We're gonna give you one form every 2 years. Like
Right.
what?
So
you
now we
know?
have fixed that problem for your mom. I see Amona's jumped on. Thank you so much for your dedication, Amona, in creating this product. As I personally know it's touched my life, and I know that it'll touch your mom's life. So thank you so much for coming on and following us and doing all the hard work that you do and taking the time out after just having a baby. We're forever grateful. And send me an email, and we're going to get started with Bra Day Part 2. Here we go.
Thank you so much, love. I'll shoot you an email shortly.
Awesome.
Mwah.
Sounds good. Thank you.
Bye, honey.
Bye.
How do I leave? Do you throw me out or do I don't know how to do this.
We're in
I
trouble
need a
now.
teenage intern. I'm
All
sorry.
right, let's see. I think you can, let me see. Hold on. All right, hold on. This is good.
I'm really just good at drawing things. That's where it ends.
Okay, remove Melanie. All right. Ooh.
Thank you.
Good evening. How are you? Hi, Dr. Bank. We can't hear you.
Can you hear me now? Can you hear me now?
Yes, I can. But we're having the other doctors can't join for some reason. Let's see. Dr. Light, are you able to join? I see you're on. And Dr. Korn, are you guys able to join? How are you? How's your day going?
Good. Busy day. Operating, seeing patients, and doing a little breast reconstruction awareness event now.
I know one of your patients messaged me and was like, how's he going to be doing a live when he's going to be at this event with me? And I'm like, I'm sure he's going to make it work.
On walks in. But I've just posted a picture on her on my stories of her. So one of my favorite.
Okay. We are just waiting for, let's see. We're just waiting for Dr. Korn to join. Hi, Dr. Light, how are you?
I'm doing well. How are you?
I'm good. Well, I know where you are, huh?
Yeah.
Where you just came from.
Well, I'm actually still here, so I'm hoping my case got a little delayed, and so I'm hoping I can take advantage of this downtime to chat a little bit before they call me away.
Perfect. So you know what? Why don't we get started with you, and we'll wait for Dr. Korn to join. He has not joined yet.
Okay.
So basically, everybody, welcome. Thank you, everybody, for joining. This is part 2 of BRA Day, Breast Reconstruction Awareness Day. This is my favorite day, as well as many plastic surgeons, because we get to take the time to educate on knowing your breast reconstruction options. I am a huge fan of knowing your options, and all of them should be offered to every woman. Dr. Feingold said something this morning. I said, there's no gold standard. He said, at NIBRA, we have a gold standard. And I thought that was a great reaction to what we feel in the community as there's not enough information that we're given sometimes when we go into, knowing what a mastectomy is or knowing our breast reconstruction options. So if you want to take a second, Dr. Light, and just introduce yourself, and then we can go ahead and get started from there.
Sure, no problem. My name is David Light. I'm a plastic surgeon, a microsurgeon, fellowship-trained microsurgeon. Dr. Bank and I actually did the same fellowship at the University of Pennsylvania. I'm a couple of years older than him, and we both joined NIBRA, New York Breast Reconstruction and Aesthetic Plastic Surgery, after finishing our fellowship.
Neither of us are as old as Dr. Israeli and Dr. Feingold that gave the history of breast reconstruction earlier today, going back.
Correct.
They started training in the early 1900s and, advanced quite a bit.
You labeled them, huh? You put them first. So Dr. Light, if you want to just go ahead and maybe go over, what are the options for patients that underwent natural breast, natural tissue reconstruction, but don't have enough tissue?
Sure. There's actually a few options. So if one natural tissue flap is not enough volume to complete the reconstruction, you can certainly use more than one, and that's something that's called stacked flaps. If you're going to reconstruct one breast, you can stack 2 DIP flaps and use both flaps for one breast. If you're reconstructing both breasts, a bilateral reconstruction, then you can combine an abdominal-based flap, like a deep flap, with a, for example, thigh-based flap, a PAP flap, or any other autologous flap. So that's certainly one option. Another option is to place a small implant underneath the flap, something called a hybrid reconstruction. And a third option is fat grafting. So one of the beautiful things about a autologous or natural tissue flap is that it's a great recipient for fat grafting. And so you can really do a fairly high volume of fat grafting and augment the volume of a breast reconstruction pretty significantly.
How do you decide which flaps to choose from?
A couple of things go into it. One is sort of where the patient has a little extra tissue to take from. And, a lot of the flaps are based on areas where everyone has a little extra, whether it's the inside of the thighs or the lower abdomen, the lower back, the buttocks. So that's certainly probably the primary consideration. But then we also look at not only the aesthetics of the reconstruction, but also the aesthetics of the place or the site on the body where the tissue is coming from. So, a patient who has laxity in the abdomen and maybe a little bit more laxity in the thighs, and the aesthetic benefit to the thighs would actually be better than the aesthetic benefit to the abdomen, that certainly may sway your decision on where to take the tissue. As plastic surgeons, we're concerned about the aesthetics of every part of the body. Obviously, the goal there is to reconstruct the breast, get a nice, soft, warm breast reconstruction. But we also want to pay attention to what we're doing at the donor site where the flaps are coming from.
Now, what's the difference between delayed and immediate hybrid flap?
A immediate hybrid flap is when the implant is placed at the time of the natural tissue flap, or for example, the deep flap. So if on the day of the deep flap, you're putting an implant under the flap, that's an immediate hybrid. A delayed hybrid is when the implant is placed under the flap at a later date. So the flap is performed, and either you're going to plan on coming back to put the implant in, or it may be a patient that had a, for example, a deep flap, and the volume wasn't quite what they wanted. They really want a significant increase at this point, and so you go back at a later date, even though it wasn't planned originally, but you can still go back and place an implant underneath it. Sometimes we choose to do a delayed hybrid for safety reasons. You know, if you put the implant in on the day of the deep flap and it has any change at all to the flow in the blood vessels and the perforator, you may take a step back for caution and decide to do it, you know, at a later date. When you come back to put an implant in 2-3 months later, the safety margin is really high. You can basically do whatever you want at that point.
You know, we always talk about fat grafting, right? How much volume can you actually get from fat grafting?
You can get a significant amount of volume. Number one, it depends on how much extra fat the patient has to actually liposuction. So that's sometimes a limiting factor. But if you have a patient that has, you know, ample extra tissue, you can put in hundreds of cc's of fat. Now, the thing that I always counsel patients on is fat grafting isn't necessarily a 1-to-1 ratio. So in other words, if you inject 300 cc's of fat into a breast reconstruction, it's not like an implant where if you put in a 300 cc implant, you'll have 300 cc's, you know, a week later, a month later, a year later. It's very stable. With fat grafting, you know, some of it will not take, some of it may be reabsorbed. So that's why we sometimes do fat grafting more than once. And that's okay. It's, you know, a pretty easy procedure. It's ambulatory surgery. So sometimes one session we'll do it, and sometimes we'll do it a second time in order to get the volume that the patient wants.
You know, one of the questions that came through is when you have fat grafting done, how does it work with your body if you gain weight or lose weight? Does that affect the shape and size?
Well, any natural tissue reconstruction, and I think it holds true for both fat grafting or a natural tissue flap, one of the great things is that it will change with you. So if you gain weight, you will have an increase in the volume of the fat cells. If you lose weight, you'll have a decrease. So many times the appearance or the sort of ratio to your body size that you have after your reconstruction maintains. Now, if you lose a considerable amount of weight, that can change. That can lead to a little bit of a deflation in the breast, and then we may need to adjust the skin. But the fat grafting and the autologous flaps will basically fluctuate in the same direction that your weight does.
And one of the questions that came through is, can fat be injected behind the nipples?
Definitely. Definitely. You know, one of the shortcomings to any breast reconstruction, even if it's a nipple-sparing mastectomy, is that a natural breast has a very conical shape to it. And the areola skin is a little bit thinner than the rest of the breast skin. And that allows the breast tissue to sort of protrude into the nipple and areola and give the breast a little bit of that slightly pointy conical shape, which is sort of what we expect and want. The problem after a mastectomy is that can be pretty difficult to reconstruct. And so fat grafting under the nipple and areola, specifically in that area, helps to build that area up a little bit and restore a little bit more of a conical shape.
And is fat grafting the same as a lipo procedure?
I'm sorry, say that one more time.
Is fat grafting the same as a lipo procedure?
Well, liposuction is part of fat grafting. So liposuction is the way that we remove the fat from the body. There's usually some sort of processing of the fat. There are medical devices that help to remove the extra fluid. Sometimes we just allow it to decant and separate. Some people will put it onto a non-stick sort of gauze to help draw the extra fluid out. And then once that sort of processing occurs, you then take the fat and you inject it into the body. So liposuction is sort of the first half of fat grafting, and then injecting it into the breast, whether it's under the breast skin or into an autologous flap, it's the second half of the fat grafting process.
And then can you get your stomach muscles sewn together since they are taking from the stomach? Does that happen?
Can you? Yeah, so sewing the stomach muscles together is basically a diastasis repair. And diastasis is, erectus diastasis is when the six-pack muscles or the rectus muscles separate. It's very common after pregnancy, even more common after multiple pregnancies. And so many times during a deep flap, we will see a diastasis. We can sometimes repair a diastasis below the belly button, and we can always repair a diastasis above the belly button. And we do. I know in the practice we all do it. It helps to improve the contour of the abdomen. It helps to improve the aesthetics of the breast, and that's, sort of getting back to the point that I was making before. You really have to pay attention to not only how the breast is going to look, but how, the abdomen or the thighs are going to look to really give the patient the best possible outcome.
One of the ladies says, what about mammography?
So mammograms after breast reconstruction are really not necessary. The breast tissue is removed, so you're not having mammograms anymore. Breast surgeons sometimes will follow with ultrasounds. Sometimes they'll do an MRI. Sometimes it's just physical exam. But mammograms are actually not typically done following a mastectomy.
And how many times can you get fat grafting done?
Technically, there's no limit. If there are some patients that will have a few rounds. In fact, patients that have, this isn't a common thing in my practice at all, but there are some surgeons that have done complete breast reconstructions just with fat grafting. And that takes multiple sessions, 7, 8, 9, 10 sessions of fat grafting in order to build it up over time. So there's no limit. It really depends on, how long it takes to reach your aesthetic goals.
Oh, perfect, Dr. Lay. Thank you so much. We appreciate you coming out, before you head into surgery. I mean, that's true dedication right there. Thank you so much.
No problem. Thank you for having me. I'm going to stay on as long as I can, but if I depart, I apologize. And again, thanks so much for having me.
Perfect. Well, thank you, Dr. Bank. Thank you so much for joining. Dr. Korn, welcome. Thank you for coming on.
Hi, Tracy. Yes.
Dr. Bank, let's go ahead and get started with you. If you want to take a second just to introduce yourself, tell everybody a little bit about yourself, and then I have some amazing questions that ladies want answers to for you.
My name is Jonathan Bank. I'm the
You're breaking up, Dr. Bank, real bad. Like we're hearing every other word.
Any better now?
Yes.
I'll change positions. So my name is Jonathan Bank. I'm a plastic surgeon at Nibra Plastic Surgery, one of 5 doctors here. We all focus on breast reconstruction and aesthetic plastic surgery. We are all microsurgically trained, meaning we're fellowship trained or subspecialized in doing complex breast reconstructions, including range of flaps, deep flaps, tug flaps, fat flaps, a whole bunch of acronyms that David spoke about a little bit, and I think Peter is going to discuss even further. We're located in New York, patients from all over the place, and we're really happy to join forces with you tonight on Breast Day, or Breast Reconstruction Awareness Day, which is recognized across the country to basically discuss options for reconstruction after mastectomy.
Our first question to you is, can you tell us about the history of nerve restoration in the breast?
Yeah, so that's a particular interest of mine, restoring nerve function, or preserving nerves during mastectomy. That's a topic that I think is sort of the next phase of focus in breast reconstruction. Pretty much the start of my practice, particularly with the natural tissue reconstructions, we attempt to reconnect nerves that were severed during the mastectomy to nerves that are transferred with the tissue that we harvest from elsewhere, the lower belly, the inner thighs. And the ultimate goal is to restore sensation to breast tissue, and that's particularly important, sorry, to the breast skin. That's particularly important for a delayed type of reconstruction where the skin envelope is reduced, and we need to basically recreate or the breast skin. So it's important for there to be feeling there for protective reasons and for other reasons. Now, that's not always achievable, but that's the goal. What I think is becoming much more achievable these days, and when Dr. Israeli and Dr. Feingold talked about the history of reconstruction, they touched on the history of mastectomies. Back in the day when everything was removed, there was really no chance for a good reconstruction or a sensate reconstruction. And in the last decade or so, one of the most common ways of doing a mastectomy is with a skin sparing or a nipple sparing mastectomy. So we have more skin to preserve. There's a higher chance that the nerves are going to be preserved as well. Now, if you start thinking about it and focusing on that, then there's the chance, it becomes less of a chance and more of a plan. So we're not just by coincidence, oh yeah, some sensation is restored. By design, we're able to protect the nerves during the dissection. We breast surgeons, but in concert with the plastic surgeons that are there to kind of point things out, help identify the blood vessels to preserve the blood supply to the skin, and the nerves run just with them. So if you're preserving the skin, you're preserving the blood vessels, maybe preserving the nerves. So I think kind of the next frontier in mastectomy surgeries is focusing on preserving the nerves. And we come in is restoring the nerves that can't be preserved. Some of the nerves traverse the breast tissue and they have to be cut. So if you can reconnect them somehow, either to the flap, the innervated skin, or the skin that has sensation transferred from elsewhere, may very well reconnect to the nerves that grew from the chest and were cut during the mastectomy. And even if you don't get the sensation all the way up to the skin edge, we do find that a lot of women say that they do have this sense that this breast is mine. Sort of, it feels more part of their body if it's connected with the nerves. That's something called proprioception. That's a fancy word to say, where is my body in space? Where are the parts of my body in relation to the rest of it? So I think that's important. We do see that with natural reconstruction, that the nerves aren't connected, but the studies have shown that there's a much higher degree of sensation and even less pain. In a recent study from Holland, that when you do attempt to reconnect the nerves.
You talked about pain, right? We talk about post-mastectomy pain. How does that relate to post-mastectomy pain, and what is breast relief?
Okay. So post-mastectomy pain, it's kind of I would say a catch-all phrase for any chronic mastectomy. And to further expand it, it can be even after any other breast surgery, lumpectomy, breast reduction, breast augmentation. There are multiple factors that contribute to it, but I think that a major contributor is damage to those nerves that are in the vicinity of the breast and chest area. If they're cut quickly, then they can be a real problem. And in large studies, there's a handful of large, good studies from across the world showing hundreds to thousands of patients. Know that based on those, somewhere between 8 and 10% of women that have had mastectomies have severe post-mastectomy pain. And it can be attributed to the nerves because of the character of the pain. That can be electric, sharp, burning, shooting pain. And it's in very consistent spots in the inner side and the outer side of the chest, sometimes towards the armpit area. And we know that that's what the nerves are. So those are the ones that I look for to connect them. Now, if we've had many instances where we've gone back to explore areas of tenderness and pain, and we found that they were surgically manipulated and damaged. So we'll find nerves that are cut, that are in scar. We'll find nerves that have clips on them. We'll release the clip, and the pain is gone. It's probably one of the most rewarding parts of my practice these days, because the lady goes to sleep with pain and wakes up with nothing. And the culprit, we find, I don't know, 9 out of 10 times. It's really fantastic. So that helps the pain. If you can reconnect that to a nerve that we transfer from elsewhere with the flap, or even reconnect it to a nerve graft, which is kind of like a bridge cable, and we can reroute that somewhere. Now the nerve has a new sort of channel to sprout into, and that's what nerves want to do. They want to sprout at about a pace of 1 millimeter a day. So if you give it a direction, there is a chance that sensation will come back at the end of that. Sometimes that's a little bit of wishful thinking, but at the very least, it gives the nerve now, instead of having a barrier, it has a channel to grow. And then that's the way to treat these things. And it's been described all over the body for arm and leg amputations and so on. That's like the phantom pain. And there are ways to prevent that, or at least to minimize it. So breast relief is kind of focusing on those issues. And the last rung of the algorithm of treating the pain is surgical. Before that, we start with physical therapy, with pain medications, with local and regional injections. So breast relief is kind of a consortium of practitioners from different disciplines that focus on that. So the last thing a lady that has had maybe multiple operations is the news that she has to go in for another one. So we don't want that. We want to maximize all the other options. And if push comes to shove, we do that. And knock on wood, it's been positive outcomes. And I'm not the only person doing this, but there are plenty of other surgeons across the country. And I think the more we talk about it in discussions like this, more and more people will be aware. We'll do more things to prevent these issues, and potentially more things to treat them.
I think a lot of women suffer in silence from, the nerve pain and post-mastectomy pain. And a lot of women don't realize what it is, or they go see their doctors and they don't know what it is. And I think it's important that we talk about it and figure out what we can do. Like you said, it's not right away surgically, but there is other options, to try before that.
Right. Definitely.
So I got a lot of messages today about you being all over the news and your art projects that you were sharing all over. And we have a lot of women that are from all over the world that are asking, if you wouldn't mind to share about these projects as they have to do with mastectomies, and that's what you guys focus on. Women are just asking, what are they? How can I be a part of them? Do we have to be part of their practice? And obviously, we refer them all back to you guys, but if you could just take a second to explain what you're doing.
Sure. So at Eyebrow Plastic Surgery, we're focused on the physical, but we understand that there's a larger picture, and we do a whole host of programming to talk about the emotional aspect of all this. One of them, probably one of the pillars of our practice in general, is the patient empowerment program run by Molly Sugarman, and she helps. I would say us surgeons deal with the technical side of things. She helps with the emotional aspect of things. So things like guided imagery, support groups, and so on and so forth. So it kind of starts there. I would say I dabble in photography and I dabble in breast reconstruction. I always kind of wanted to combine the two. And a few years ago, I connected with a spectacular photographer who has a large heart and um, the sensibility to connect with women that have breast cancer or preventative mastectomies and reconstruction. And the first project we did was called Reconstructed, that borrowed conceptually from kintsugi, the Japanese art form of reconnecting broken pieces with fragments lined in gold. And we created a book and a gallery, and somebody's actually flying in from London to film a documentary on it next couple weeks. That's to kind of show that we can be beautiful, or even more so, despite the adversity that we went through. So that was Reconstructed. Dr. Israeli and I, one of my partners, are working on, completed working on a project called Restored that expands on his original live casting project, that he took women in various stages of the reconstruction and cast their bodies, displayed it at the big plastic surgery meeting where he and I first met and eventually became friends and partners and collaborators. And we teamed up again with that same group of creative photographer and creative directors, and with some sculptors, and we cast women in their various stages of reconstruction. And this time we created sculptures out of different materials depending on their personality, their story, and so on, and then photographed the whole process and the outcomes. So that's coming out in November. And right now I'm at an event on Broad Day for another little kind of coincidental serendipitous project called Before the After, which is a series of accidental snapshots that I took of women. As you know, we take before and after pictures to plan for surgery and to learn how to improve on our work. And one of our first patients, actually Dr. Korn helped me with this lady in the early days of my practice. She had no reconstruction originally, and then we performed a delayed DIP flap or D-flap reconstruction on her. And in the pictures before surgery, when I took the pictures of her whole torso, I got the bottom part of her face where she has this grimace on, which is just like, get me out of this room and shoot me now. And then almost a year later, after she went through all the stages of her reconstruction, we got to know each other a little bit better. At the end of the day, I took another picture of her whole body, and she's just standing there beaming with this upside down smile, but you can tell that she's just a changed person. And whenever I give talks on breast reconstruction, I talk about implant reconstruction, no reconstruction, flap reconstruction, immediate reconstruction, and delayed reconstruction. I will show a picture of Mary. I show that was delayed, not just a delayed breast reconstruction, but a delayed confidence reconstruction, delayed self-esteem reconstruction, and delayed smile reconstruction. And I zoom into the bottom part of her face, drop all the rest, crop all the rest out, and show what really matters. So that was kind of how Before the After started. And then we teamed up with Canon, that are also here in New York, also main sponsors of the Making Strides event against breast cancer for the American Cancer Society in Long Island. And so I have this idea, all these pictures we're taking on our Canon cameras, let's do something together. So we came up with this project together, and then I went back and looked at found a couple dozen of parts of faces, some with teeny smiles, some a lot larger, and that's Before the After. I asked each woman to write a little bit about what she feels looking at those pictures. Sometimes I got just a couple of stoic lines, and sometimes there were, 10 paragraphs, and it gave them a real chance to look back at where they were and where they are now, and a little bit of a catharsis for them, and definitely a message of hope for women that are in similar situations or maybe in the future. So that's the whole idea behind these projects, and just gives a little bit more meaning to what we do.
And I think that often we forget to take pictures before and after, but knowing we can go to our doctor's offices and get them, it's different. But then when you capture the moment, or you give a woman, your casting or your pictures when you're done, I think it kind of gives them a different perspective of my new normal and how I feel. And I'm so beautiful and this is me. And, we focus on a lot of photography projects as well, because again, I think it's important to help not just let's get through the journey, but after the journey and how you feel and getting you to feel and accept and love your new normal. So I think it's so important, and thank you so much for sharing that. I don't know, before we pass it over to you, Dr. Korn, we did get a question on, can you talk a little bit about flat anesthetic closure? So I don't know which one of you want to talk about it, or if you want to start, Dr. Korn, it's totally up to you.
I'm probably going to disconnect now to join this event that we're having here. Maybe I'll send some photos later, but I'm going to let Dr. Korn take charge.
Perfect.
Okay. All right. So, sorry, what was the question?
So I guess let's just start out with, thank you for coming, Dr. Korn. We appreciate you coming on tonight.
Yeah, sure.
And maybe if you just want to take a second and introduce yourself, and then we can go ahead and get started.
Yeah. So I'm part of the same group, Nipple Plastic Surgery, and one of the 5 partners. And I was lucky, I think, that I started my career in plastic surgery, including my training at Cornell and then my private practice, at a time when breast reconstruction really took off in a way that a lot of the procedures that we do nowadays were really new and described, and so I was kind of in the beginning of when all that happened, and certainly found my passion in doing those procedures. And since then, I've done obviously a very large amount of deep flaps and have introduced other procedures that David talked about a little bit, like the tuck flap, the PAP flap, or the LTP flap in the community. And so anyway, so breast reconstruction is certainly a very large part of my practice, and obviously a passion of mine. So.
My first question to you of the night is, from a patient's perspective, what are the main options for breast reconstruction, and what are the reasons to decide from one over the other?
Yeah, so that's probably what I think I spent the most time, and I think it's the most important part of any breast reconstruction. As we have heard, there are many excellent options for breast reconstruction, but that makes starts obviously with a decision-making process, and that's might be sometimes the hardest part in the journey of having a mastectomy and a breast reconstruction. And with all the information that is out there on the internet, and it certainly becomes sometimes hard for patients to filter, what should they choose and for what reasons should they choose one or the other option. And I always think it's important to understand what are the important reasons, and focus on those reasons, and you need to understand which reasons are really not that important to focus on. And I often see patients that come to the office and they say, they don't want implants, they don't want to have a foreign body in them, and I think that sums it up kind of. And then other patients say they don't want to have anything done to their belly or any other part of the body. And that also kind of sums it up. And it's essentially, implants give it instantaneously the volume that we need for the reconstruction, but they are foreign body and they need maintenance down the road. And those are really the important things to think about. They have more potential for some little issues, and you need to count on that you're going to need surgeries later on in your lifetime. And the reconstruction is never quite as natural as having your own tissue. On the other hand, you can have an implant reconstruction that offers any sort of volume that you need, and you don't have a scar anywhere else on your body. The big appeal of using the flap reconstructions is obviously that you have a more natural reconstruction, and you have something that will last. Once you have a completed reconstruction, you have something that's maintenance-free. You can move on with your life. The patients who have deep flaps, I see them more commonly at some functions or events, rather than in your office, and they're very satisfied. They don't require to come back to the office every year, and they don't need to count on needing additional surgeries later on in their lifetime. The downside of the deep flap, in my mind, is the scar on the belly, and it's a relative disadvantage. A lot of women, if they have some extra tissue and laxity and they don't mind repurposing it for something else, they accept the scar very happily. But somebody who has a thin belly, the scar, might be a deal breaker. And also, if the belly is very thin, sometimes the result of the deep flap may not, give us enough volume, and the shape of the breast may not turn out as well. So it certainly needs to be decided on a very individualized basis.
If you could touch base a little bit on flat anesthetic closure, a lot of women are asking, can you talk about it a little more, as it's not offered and people don't consider it a breast reconstruction option. And I think it's important that we let women know it is an option.
A flat closure, you mean?
Yeah.
Yeah. So sometimes when I see patients who don't want to have a formal breast reconstruction, I think what I typically recommend is what's called a Goldilocks procedure, which is kind of in between having a formal breast reconstruction with bringing either tissue or an implant in to replace the volume. But it's more than just having a mastectomy where all excess tissue is removed and everything is just closed in a flat fashion. When you have a mastectomy and you have some excess skin, that skin can be utilized, and it can be kind of closed vest over pants in order to still create a little bit of a breast mount, have a little bit of something that looks reminiscent of a breast. We can also do an immediate nipple reconstruction at the time. And also the scars are placed in a location where they're much more favorable, meaning right in the fold under the breast, as opposed to, going across the center of the breast. So these Goldilocks procedures in the right patient certainly, are a very good addition, because they allow patients to have a procedure that is, in terms of recovery, not more than just having a mastectomy, but the outcome certainly looks more attractive. And in certain cases where there's enough spare tissue available, pretty decent breast shapes can be achieved this way. And so it's not really a flat closure. But that's what I would recommend in somebody who doesn't want to have a formal reconstruction and still, wants to have a aesthetically pleasing result.
Which is the better option if you're thinking of having children in the future?
Yeah, so that's a very good question. So it depends on what the belly looks like, really. I think I certainly had a few patients who had deep flaps, and later on they became pregnant, and there's nothing wrong with that. It's not going to make the pregnancy more difficult. But obviously you lose a little bit the benefit of the belly tightening that you get with the deep flap. If I see a young patient who expects that she's going to become pregnant at some point, I often recommend, doing an implant, and obviously the implant doesn't burn any bridges. And later in life, when the situation changes after pregnancy, when there's more skin laxity, I think then, you can always take the implant out and convert it to a deep flap in order to get a more, natural and more long-term result that will last.
So can small-breasted women with little fat get a good result with Goldilocks?
Yeah, so that's a little bit more challenging. So obviously the Goldilocks works better if there is some excess skin and laxity in the breast and ptosis. Because then we have more tissue available. With the Goldilocks, you can certainly, we work with what we have, and we don't bring anything in from somewhere else. So there are some limitations to the procedure in thin patients with smaller breasts. Yes.
When do you recommend reconstruction with implants, and when do you recommend with tissue flaps?
Yeah. So I touched a little bit on that. So, I think overall in the right patient, if the patient has some tissue on the belly and the patient doesn't mind the scar, or a lot of patients, as I said, welcome the scar for the tummy tuck type closure, it's not a bad trade-off. In those patients, I do think that the deep flap is certainly gives us the best breast reconstruction. And that's typically what I would recommend, unless the patient has some concerns, or, as I said, doesn't want to have surgery on the abdominal skin done. The implant reconstructions are obviously, if I feel that the flaps won't give us enough volume to shape a beautiful breast, or if they have a beautiful abdomen and want to avoid any scar on it, then I think the implant obviously gives us, the option of a good reconstruction that might be the right choice for this patient. And I think implant reconstruction also have certainly come a long way, and I'm much more happy, with reconstructions, with placing the implant in front of the muscle, where we don't need to elevate the muscle anymore. I think I've become much more happy about implant reconstructions than 10 years ago. So
It's definitely advanced, that's for sure.
yeah.
So what if I had deep flap surgery and lost a lot of weight and the breasts deflate? What can be done at this point?
So David talked a little bit about fat grafting. Obviously, we can try to restore more volume by doing fat grafting. We can also, essentially, like in somebody with natural breasts, we can do a breast lift. Once everything is healed, you have viable tissue there. You can pretty much, do everything with it. You can, trim some skin to give the breast a lift and reshape it, and then the fat grafting, I think, is an excellent tool to fill in some areas where we need to give it extra volume, and also to potentially increase the overall volume of the breast a little bit.
Can you explain a little bit on unilateral versus bilateral, and what are the advantages, and how does it affect the choice of reconstruction overall?
Yeah, so also very common decision-making scenario in the office. With patients who have a genetic predisposition, like BRCA patients, obviously the decision has been made essentially, but patients who have cancer on one side, the most common questions again are either to use a tissue reconstruction or use an implant, and the other question is, should I do the other side or just do one side? In my practice and in our area, certainly the trend has been over the last 10, 20 years to do both breasts, and I think there's a good reason to that. From an oncologic perspective, it obviously gives patients much more peace of mind that they don't need to have annual mammograms for the other breast and potential biopsies. The younger the patient is, obviously, the more meaningful that is. If you have a long life expectancy, then obviously the chances of something happening to the other breast, will accumulate. And so younger patients certainly feel very strongly about doing a bilateral mastectomy. Now, when it comes to the reconstruction also has, great implications there. I always think that an implant reconstruction doesn't look very satisfying if you just do one breast. It just behaves very differently than a natural breast. Implants always have more projection. They're typically a little bit higher. And when you lay down, the implant will always, stay more projecting versus the natural breast that flattens more out. So with an implant reconstruction, I think symmetry is important to us, and I think bilateral procedures certainly have a much more satisfying. And with deep flap procedure, especially the deep flap, you also need to be aware that this is a one-time shot. You can't have a deep flap to one breast and then later on, should you have an issue with the other breast, do the same thing to the other side.
Well, I didn't know that. That's an interesting.
Yeah,
So right now, if you go in and you have one breast and you have a deep flap done, right?
Yes.
And then in 6 months you decide you want the other breast done, you can't do that?
The deep flap is gone. So once you take the tissue from the belly, you close it like a tummy tuck. You can't just take half of the belly and leave the belly lopsided. So the deep flap is a one-time opportunity, and that certainly, also affects the choice, and may stir some patients to do a bilateral mastectomy. There are obviously other choices. You can still have a tuck flap or so, but if you have enough tissue on the belly to reconstruct two breasts, and the majority of women do, We always, I think, get the most satisfactory results if we do the same thing on both sides, have a symmetrical result, and in my mind, I see also the most patient satisfaction in that. And it always, from an oncologic perspective, I've never had a patient regretting doing both sides. It just gives them a tremendous peace of mind that they, don't have the annual screening and potential further issues on the other side.
How many surgeries in average would you need to have a good reconstruction? Well, that's a good question.
How many procedures? Yeah. So very good question. I aim for one procedure, but so typically the majority of patients have two procedures, especially with the deep flap. There's obviously the immediate reconstruction at the time of the mastectomy. And then the majority of patients come back for a second procedure where we have just different tools available. We do liposuction, which helps keeping the belly in good proportion and, addressing any potential contour issues on the belly. And the liposuction gives us the fat grafts, which will help us to round out the breast and make the breast as symmetrical and as round and smooth as possible. And if the nipple needs to be reconstructed, that can be done at the same time, obviously. So we have different tools available for that secondary surgery, and it makes a nice difference. Patients who have an immediate reconstruction with a deep flap, I think the great majority, will be fine after that second surgery. So that's what I typically see. The initial surgery at the time of the mastectomy, and then 3-4 months later, an ambulatory procedure with minimal recovery time, where we do some tweaking and fine-tuning just to make the result look as good as possible. With implant reconstructions, I tend to do a direct-to-implant, so I want to avoid the tissue expander step. And with the pre-pectoral breast reconstructions that we use nowadays, I don't really see the importance or the role for the tissue expander that much anymore. And I would also say that the majority of patients come back for a secondary procedure, and then obviously they need to count on that later in their lifetime. They will need probably some implant adjustments and exchanges. And the data tell us that the likelihood or the average time frame is about 7 to 10 years for that to happen.
Can you touch a little on tug flap and what could be expected compared to deep flap if you're not a candidate for deep?
Yes. So the tug flap has been my second favorite flap procedure for breast reconstruction, and it has remained that. A lot of women that have a very thin belly still have enough tissue in the upper thigh, and that can be used for the tug flap reconstruction. The majority of women have enough laxity and tissue on the belly, and are also glad to have that tummy tuck aspect of the deep flap, so that remains 90% of patients remains the first flap option. But the tug flap has some significant advantages also. The tissue is very soft, it feels very breast-like, and the way the tug flap can be designed, and when I started doing them, I described it what's called the fleur-de-lis tug flap. It can really create a very nice projecting breast shape, nicer than many deep flaps. I think some of my best breast reconstructions are probably tug flaps, and so it usually gives us the volume also in thin patients and gives us very nice breast reconstructions. The scar on the thighs is not think it requires a little bit more maintenance than the belly initially. And in terms of the donor side, I'd rather use the belly if there's enough tissue available. But I've been very happy with my tug flap results as well.
Is there a fix after a deep to the extra upper pubic fat and tissue that can sag?
Yes. It's actually a fairly easy fix. What happens is that there's sometimes some scar tissue, some deep scar tissue that builds up beneath that area. And then kind of that fatty tissue in the suprapubic area kind of just bunches up and becomes more prominent. What I've done in patients where that happened is you can just open the abdominal scar, and then from the inside, release that scar tissue, and then it just flattens out again. So it's actually a fairly easy fix. Sometimes if there's just excess tissue, it might also be done just with liposuction by itself. But I found just releasing that internal scar tissue is a very reliable and easy fix for that.
And what's your advice with women who have frequent implant flipping?
Yes, so I've seen a few patients, and I've seen this only really with one particular kind of implants, and I have a couple patients that come to me every few months or so, and when they notice that something doesn't look right, and usually I'm able to just manipulate the implant to flip it back. But if that remains an issue, then you can, the implant can be exchanged, usually to a different type of implant that we don't see implant flipping to be an issue as much. And maybe the pockets, the tissue pocket the implant sits in, the capsule, can also be modified in a way that the implant stays in position better.
Now, thank you so much for this informative information and sharing with the community. And
My pleasure.
as we're getting ready to close out, if there's any questions that weren't answered, please feel free to send me a DM and I will get them answered by one of our physicians as soon as we can. As we're closing out, as I always say, Broad Day is really important to the community, and it's not just October, it's 365 days a year. From a physician's perspective, what would your advice be to the women out there who are searching their breast reconstruction options?
It's obviously, I think the best advice is to go to a practice that has, that really focuses on breast reconstruction and has offers all the options that are available and can really individualize a treatment plan. Breast reconstruction has really become a specialty by itself, and the procedures are very advanced, and what we say have a long learning curve. I think it takes a few hundred deep flaps for a surgeon to really become good at it, and you want to be able to offer the deep flap with a success rate of 99.5% or greater, and you want to be able to offer that with a straightforward, quick recovery. And for implant procedures, it's the same. I mean, obviously, implant procedures are offered by the great majority of surgeons, but there are also a lot of nuances to it. And I think just going to an experienced plastic surgeon is probably the first best step. There's a lot of information on the internet, but some of the information needs to be taken carefully. And as I said in the beginning, I think there's some reasons why to choose one procedure and other reasons that I think are not as important. If you hear about the deep flap being a long, complicated, and difficult procedure that has a significant failure rate, that's not what I see in my practice. That's why I tell my patients, for instance, that the scar on the belly in my mind is a much more important factor to decide for or against the deep flap. But overall, I think we have come a long way with the options that we have for breast reconstruction, and we just need to individualize, what makes the most sense in a certain body habitus, but also, what works in a certain lifetime situation of a patient. As you mentioned, young patients with kids, patients who want to become pregnant. Everybody has different priorities, and all this needs to be put together to make the right decision.
You said it, like, know your physician, know your options, and look for a practice that has a group of physicians working together on a mission, like you guys are at NIBRA, like continuous education, sharing information, teaming up with different communities out there to make sure that women know their options and know what they're facing and know that it's not just the actual outcome of your surgery, it's getting through your surgery and preparing for your surgery and knowing again, you know, what your options. So I really want to thank all 5 of you from NIBRA for making this bra day happen this year. And it has been a true inspiration for myself as I always learn from all 5 of you and really are grateful and thankful for everything you've done. And I do see a couple of questions that are coming in. Can they go visit Dr. Korn from another state or NIBRA? Yes, you can. You can feel
Yes.
free to go on their website or reach out to their office. If you have any questions, you can feel free to reach out to me, as well as we also have a transportation service if you are in another state and do need to get flown to New York to see a physician for a consultation, for surgery, for genetic testing, for clinical trials. You can always feel free to reach out to us because we're more than happy to get you out there and support you and make sure that you're making the best decision, as we're here for you all the time. So thank you, Dr. Korn.
Thank you for having me, and we are always available for virtual consultations too, if the distance is prohibitive otherwise. So, but thanks for having me, Tracy.
Perfect. Be well. Take care.
Take care. Bye bye.